η ενότητα αυτή αφορά ουσιαστικά παρουσίαση περιστατικών και νομίζω η ιδέα είναι να υπάρξει αλληλεπίδραση ανάμεσα σε εσάς και σε εμάς. Γιατί θα προσπαθήσουμε, όλοι οι ομιλητές θα φέρουν αληθινά σενάρια, τα οποία θα τα δείτε στην καθημερινή σας πρακτική και σκοπός είναι να βρούμε μια λογική αντιμετώπιση όσον αφορά πάνω στο management αυτών των περιστατικών. Γι' αυτό νομίζω δεν έχει αντίρρηση, κυρία Λαμπρινουδάκη, ότι παρουσιάζοντας και εξηγώντας το περιστατικό, αν μπορεί να διακόπτει το ακροατήριο και να γίνεται μια αλληλεπίδραση πάνω σε αυτό. Εγώ, αν θέλετε, για λόγους hospitality, καλό είναι αν μπορείτε να μιλάτε αγγλικά για να συμμετέχουν και οι συνάδελφοι από το εξωτερικό. Και μετά αλλιώς θα μεταφράζω.
Sorry. So, this session is going to be practical, and I'm going to continue from where we left it yesterday evening. So, it's about osteoporosis. So, here we have a 52-year-old woman. Her last menstrual period was 9 months ago. And her mother has dementia and a hip fracture at the age of 71. And as you heard before, she has lived through all this, and she's worried. And she comes to you to ask about osteoporosis. And actually, because of her family history, we give her DEXA, and we see that she has a T-score at the lumbar spine of minus 3.3, and at femoral neck a minus 2.8. So she has osteoporosis. She has already been to her GP, and because she has upper GI problems, has GI reflux, her first option would be bisphosphonates, but her GP told her that bisphosphonates were not an option for her because of her GI problems, and he prescribed her denosumab. This is very frequent in our everyday practice, and she comes to you for a second opinion. As you know, it's very usual here in Greece to take a second opinion. How would you advise her? So, let me present you some things first, and then we can discuss. Of course, it's a 52-year-old lady, and as she comes to an endocrinologist and not to an orthopedist or a rheumatologist, we have to inquire about her menopause and her problems. And we have to make a checklist about the menopausal symptoms and if there are some of them. I will not go through them. You have heard them many times before. When you ask, she has not come for her symptoms, but during taking the history of this patient, you see that although she has not hot flashes, she suffers from deranged sleep. She has inability to concentrate and to recall names, and you have to evaluate the symptoms in the context of her daily life. She is a teacher, and it is a problem for her not to recall names. Furthermore, you have to inquire about chronic disease and about family history, medication, lifestyle, and anthropometrics that have to do both with her primary problem, osteoporosis, and with the eventual medication you are going to give her. So taking the history, it's the GI reflux, you know already, but she's on proton pump inhibitors. Her mother has dementia and hip fracture, normal BMI, normal blood pressure, nothing else except a low dietary calcium intake. This is the standard protocol for investigating osteoporosis, and this patient has osteoporosis based on the T fracture, the T score. So beyond the routine examinations, which we are going to prescribe anyway, we have to evaluate which more procedure we are going to prescribe if indicated. This is a personal view. Of course, we can discuss about the additional tests needed for this patient. I would prescribe a lateral radiograph to see if there are prevalent fractures, because this is going to change our management. I would like to see a calcium metabolism in parathyroid hormone and vitamin D levels. I would like to have a urinary calcium excretion, because this is a manageable condition if there is high excretion of calcium. And as celiac disease is rather prevalent and rather undiagnosed disease, and often osteoporosis is the first presentation of the celiac disease, I would like to perform a screening for celiac disease. I wouldn't prescribe the rest of the tests that are listed here. So she has been through all of this, and the only thing we realize she has low vitamin D levels. So we have a patient that has osteoporosis, minus 3.3 at the lumbar spine, minus 2.8 at the femoral neck, a family history, a low vitamin D, low calcium intake, and a medication that probably affects her bones. And moreover, although the patient does not complain, we know there are symptoms that might get benefit from menopausal hormone therapy. However, she has come for the osteoporosis. Before we proceed to the management, as you heard before, and according to our national guidelines, we have to perform the FRAX score in this lady. Here is this for you in the Greek version. She's low risk, as you see, according to her 10-year risk for fracture. These are our therapeutic options for osteoporosis. You heard them before. She has already had a prescription for the nosumab, and she comes to you for a second opinion. And if you like, we can discuss about her treatment options. Is the nosumab a sound treatment option? Would you prescribe it for her? She has GI reflux, she has gastritis, so then probably bisphosphonate would not be a good option for her, so the nosumab might be a good option. We have SERMs. May we continue?
What's MHD?
So, yes? Mm-hmm.
Then see you're going to give her properly drugs for osteoporosis, I think.
Mm-hmm.
First excluding if she's a candidate for HRT or not. I think the first thing to do.
Okay.
For SERMs, it would be, I think, a good idea, but I think she has symptoms like...
She has symptoms, and she's too close to the age of the... Oh, yes.
Not treating candidates for
Mm-hmm.
drugs, it's based on the thing that maybe the T-score is very low, but the FRAX score, because of her young age, is not indicative for international guidelines.
Yes, you're right.
Guidelines,
I agree with you. Mm-hmm.
So, I mean, can she take hormone replacement?
This is an option.
Does she have any contraindication? I'm asking because I'm not
Mm-hmm.
an expert on that, but I think
Yes, we have to explore it.
but because she has some issues with her work, right? I mean, that was my understanding.
Mm-hmm.
Instead of focusing on her work, and from all this medication, only the HRT is for sleep, right?
Yes. If I may comment on this, her main fear is osteoporosis, and having a T-score of minus 3.3, this gives her an extra fear. So what concerns her is whether the treatment we are going to prescribe her will cover her in terms of fracture management. So this is what we have first to explore. And let me give you some data on this. So as our colleague said, of course, menopausal hormone therapy would be a very good option because this is the primary indication. Reduction of fracture risk in patients with menopausal symptoms. And beyond this, as we heard before, we have many other benefits. But is it effective for fracture management? And this is what I'm going to present to you in the next few slides. So this is the latest analysis of the WHI. It's 2013 by mentioned colleagues. Among all other outcomes, here you see the fracture rate. And it's very clearly documented that both fractures, vertebral, non-vertebral, and hip fractures, are reduced by the use of hormone therapy. And what is important, this is the only treatment that has proven efficacy in the general population with average fracture risk. The other medications are effective in high-risk populations. Of course, if you design a medication for fractures, you have to select high-risk populations. But WHI has proven that hormone replacement therapy is effective not only to the high-risk population, but as well in the general population. So according to the latest guidelines, HRT with grade A recommendation is effective in reducing fractures in this population, vertebral, non-vertebral, and hip fracture, which is a very delicate endpoint. Not all osteoporosis medication can reduce hip fracture. The point is about the dose we are going to prescribe. As you know, this is a perimenopausal woman, 52 years of age. We are not going to prescribe standard dose HRT. We are going to be around low dose HRT. So is this low dose HRT effective in terms of fracture prevention? Before the publication of the WHI, you see here the work of Professor Stevenson, who has studied the low dose formulation. We have it here, if we cut it in two, half the pill of the femosome. So if you prescribed 1 milligram of estradiol along with various doses of dydrogesterone, you see a very nice increase in terms of bone mineral density, even at the 6 months of treatment. So it is effective. And this work were followed by other works from Marco Gamacciani, who showed exactly the same result, that low doses are effective in terms of increasing bone mineral density. If we want to compare the effect of low dose regimens, we can say that it is equivalent to the effect of SERMs in terms of bone mineral density increase.
That's on the spine, because on the hip,
Yes.
the spine. Yeah.
All medication produce a lesser increase of bone mineral density at the hip. What especially interested in after the first years of menopause is the effect on the spine, because it's this side we see differences after the menopause. And here you see a later analysis where a combined low-dose medication is compared with tibolone. And you see here that in young women, that was a question yesterday, combined low-dose HRT is better with respect to bone mineral density effect as for tibolone. So tibolone, it's not a good drug to be used so early. On the other side, tibolone is a very good drug to be used later. This is the LIFT RCT, a very good trial, which was published 10 years before. It showed that 3 years of half the dose of tibolone in older women, 65 years of age, could effectively reduce the rate of vertebral fraction by approximately 45%. And what more, it could also reduce non-vertebral fracture. So tibolone is also an option, but for older women. This is a review that was published last year in JAMA, where all RCTs after the WHI and the WHI included are evaluated with respect to fracture risk. As you see here, altogether it's 40,000 patients. And the net effect was that even low doses, because this meta-analysis includes also RCTs with low doses, can effectively reduce the rate of the fractures. And a last statement about post-stopping HRT, what it is going to happen when we stop HRT. You heard yesterday that there might be a rebound effect. Well, this analysis from the WHI proves that this might not be true. So the investigators followed up these women after they stopped HRT for 5 years. And they saw that with respect to the combined therapy, estrogen and progestin, there was no effect of a rebound phenomenon after the stopping of the HRT. While the women who took only estrogen, 5 years after stopping HRT, they did still have a residual anti-fracture efficacy. So, the treatment option for this lady, we decided that hormone therapy would be a good option for her because it will provide anti-fracture efficacy and will treat her symptoms. And what would you like to have for initiation of HRT? Would you perform a mammography, transvaginal ultrasound? What additional tests would you like to have for her in order to initiate HRT?
But it should be get standard, right?
Well,
No, I'm not for this reason, but no, not for that. But if there's no reason.
Yeah, well, but pap smear is screening.
Screening,
So,
yeah.
I mean, if you have a screening program, that takes care of it. If you're in a situation where you don't have a screening program, then opportunistic.
That was my point.
Okay,
It was,
that's fine.
yeah, not because of a specific reason for that. There's no
It's
correlation.
opportunistic.
Yeah. Can I ask you something?
Mhm.
You know all this debate about frequency of mammograms and self-examination, breast awareness,
Yeah.
and all that stuff. So, mammography. If she had a mammography 2 years ago, that would be enough. And she says, you know what? I read some stuff that I don't need to have a mammogram every year, right? And,
yes, the screening mammography program differs according to the country.
Yeah, that's
Some
what I-
countries have 2-year screening mammography programs. We have annual, for example, so it varies according to the guidelines, the national
How old is
guidelines,
she?
I mean, 52. I would do a mammography, if you ask me.
What about breast exam? Old-fashioned breast exam.
Breast. As a screening method, breast exam alone does not offer much.
Self-examination?
It's not good. I mean, mammography itself is challenged anyway.
Yeah,
Because one of the
it's-
concerns about mammography is that you're picking up diseases which are never going to kill the woman whatsoever. But the balance between the amount of surgery you do versus the pickup rate, that's all questionable.
Το δικό μου είναι ανοιχτό.
Sorry.
Oh, yeah, sorry, I beg your pardon. I'm very. I understood what you said. I have no idea what you said, but anyway, I kind of got the idea.
So basically, it's a hot debate about
It is.
mammogram self-examination, examination by the physician. It's a big thing. I mean, whether there's actual improvement in risk reduction and whether this intervention just increase morbidity because of unnecessary interventions on women's breasts. So there's a big debate.
No,
Ultrasound.
It's not a good screening method, ultrasound. If you want to screen, you will perform mammography. And additionally, if required,
Yeah.
you will perform an ultrasound.
What's the transvaginal ultrasound for?
That's a good question.
I would like to have it discussed.
You see, that's I think it's a very logical point, because if you look at countries that have a national health system, this is not part of the annual exam, transvaginal ultrasound. It's only pelvic exam, is that, and then only indicated. Is that right? I mean,
Yeah, it's only if I mean you shouldn't. you should do a test. There's various reasons you do tests. One reason is you're forced to do it for protocol reasons. You would hope that's worked out appropriately. Unfortunately, there will be cases where I've no doubt medico-legally you're driven to do it for a variety of reasons. But if you're doing a test, the logic is what is the value of the test? And a transvaginal ultrasound, it's a bit like, I suppose, an ECG. You can have a normal ECG in the morning and you die of your heart attack in the afternoon. So I'm just wondering why we do tests, is just to make us feel good.
And I think I agree with 100% with his point, because what would be the finding in a transvaginal ultrasound that would preclude you from giving hormone replacement therapy? Is that, you agree?
I'm just wondering what.
If she has a cyst
I'm
in
no
the
expert
ovary,
in this. I just have no
let's
idea.
say you find a cyst in the ovary, is that a contraindication for hormone replacement therapy for this woman?
No.
Only endometrial hyperplasia?
That's it. Okay, what do you mean by endometrial hyperplasia? Huh?
I'm asking you.
Endometrial hyperplasia is a histological, a pathology term. Endometrial thickness
thicker
is,
endometrium.
and I can tell you, which is something probably which is I have a big debates in this country. There's no study to show that thickened endometrium with no bleeding has increased risk of endometrial cancer. The standard of care here is if you measure in a postmenopausal woman, because everybody gets a sonogram in Greece, if the thickness of the endometrium is high, everybody gets a DNC. But if we want to talk about evidence-based medicine, there's no data to show you that in a postmenopausal woman with thickened endometrium, more than 5 millimeters, with no bleeding, I don't know.
It's the same. We're getting the same in the UK, where they're doing CT scans and saying there's a thickened endometrium. The whole premise for doing testing on the thickened endometrium is based on, first and foremost, they have postmenopausal bleeding. Then they analyse statistically where the cutoff rate was, and it came out, as you say, about 5 millimeters. That could have been 10 millimeters. But what's happening in the medical sphere is they're saying anything over 5 millimeters is now abnormal. It's not abnormal. It's only a statistical model to work out that the intervention is cost effective. And that's been transformed, and everybody starts looking for things. And what happens then is they do the DNC, they find a hyperplasia and say, isn't it brilliant? Look what I've done. And forget about the other 500 or 1,000 DNCs they did and found nothing. So you get all this bias coming in, and it takes momentum. It's I'm constantly explaining to people, it could have been a cutoff of 20 millimeters. It's just maths. That's all.
But it is not only thickness here. You have to find out what is the junction between, qualitative, analyzing junction between endometrium and myometrium. If it is rough, then this is a risk factor.
Is it risk?
Is it?
For what?
Yes, it is.
For what?
For endometrial hyperplasia, so we have to check the endometrium by pathology examination.
I'm not aware of that. It's the first time I've heard it. Where's the evidence base?
Maybe 15 years ago, not only my group, but the others also. So we have
Yeah.
to check the quality, not only the thickness.
So let me, I'm sorry, so if you have an irregularity there,
Yes. And let's say that
no bleeding at all.
bleeding.
What is the incidence of atypical hyperplasia or endometrial cancer as compared to the general population?
it is more than general population. I mean, you have data through PubMed, you can check it.
Oh, well, look at that, because that hasn't taken off. People aren't using that internationally. And you do have to justify what you're doing.
I wasn't aware of that.
Neither was I.
It's indication to check the endometrium before starting HIV.
I mean, from my point of view, I don't see enough evidence for that. I mean, if we want to talk about, we do it in Greece. I can tell you that we do it in Greece. The reason I used to practice in the States and we never did it. I came to Greece and I do it every year. The reason I do it is because everybody else is doing it, and I can tell you I do. I do it because if I don't do it, everybody else will say, "Oh, you didn't do it," and then I'm just getting tired of explaining why I didn't do it. So I go ahead and do it, and I can tell you that I have done a lot of unnecessary DNCs and hysteroscopies because I didn't find anything. I mean, I can't remember a single case with thickened endometrium with no bleeding that I found an endometrial cancer.
Yeah,
I found some polyps, but nothing more than that. So I don't know.
If it has cysts inside, if it is not, usual, this situation, this is another indication for aspiration at least.
And the aspiration comes back negative, and it's still cystic, then you're going to do a DNC and you end up with a
That's a hot
hysterectomy.
topic. I think I think we have to make a debate about that, but I think we can move on. I'm sorry for that because
Sorry.
for the next speaker because it's a very interesting debate. We can,
Just to wrap up,
to wrap up.
we have to do mammography. And
But
about the
mammography, I think is the most.
transvaginal ultrasound is a big debate about this. So you heard it. We are going on. I did a transvaginal ultrasound because, as Professor Vlaho said, everybody is doing in order to start HRT. Usually, anyway, we do not find anything. So, what we're going to give? This patient is perimenopausal, so we have to commence sequential hormone therapy. We will start with 1 milligram of estradiol per dose or 25 to 50 micrograms transdermally. And you can use what progesterone you like according to the preference of the patient and according to your views about the safety of the breast and the bleeding profile you would like to have. So you can choose between natural progesterone. She has to have sequential therapy, so you have to use 200 milligrams from the day 1 to 12 every month, or the dydrogesterone, 10 milligrams, or you can move on to the most potent progestogens. You can use norethindrone either transdermally or per dose, and finally you can use also levonorgestrel. And don't forget in this patient that you have to prescribe calcium, of course, and high amounts of vitamin D. This is very important for her. So I've run out of time with one case. I have one more. Shall I continue?
Oh.
Yeah, but I'll be short. Mine is going to be very short.
Okay. So our second patient is younger. Is 42 years old. Her last, her last period were 6 months ago, and the presenting symptoms, menopausal symptoms, typical symptoms, hot flashes, and amenorrhea. However, her periods became irregular already 2 years ago. So her doctor very wisely started her on menopausal hormone therapy, sequential regimen with 1 milligram of estradiol combined with 10 milligrams of dydrogesterone, cyclical therapy, and she had good symptom control, satisfactory. However, her periods resumed but were lighter than before. This patient was very health concerned. She had 2 children. She breastfed her children for 2 years each, and she did on her own, and bone mineral density is very frequent in our country. And here are the results, normal, both in the lumbar spine and femoral neck. And after 2 years, the patient decided on her own again to repeat the DEXA measurement, although her doctor advised her against it. And what did she find? That at both sides, and especially in the lumbar spine, there was a 10% decrease of bone mineral density. And she was terrified and asked her doctor, what am I going to do? I'm going to get osteoporosis. So,
Can I ask you something?
yes?
It's a practical question.
Mhm.
Do you consider in a woman that is taking HRT, are you considering T-score or how do you consider her? Because she's taking therapy.
Yes, she's menopausal. She's,
You consider her as menopausal?
Yes.
So you consider T-score,
yes. Mhm.
not Z-score anymore.
Is she
Exactly.
taking calcium and vitamin D?
Good question.
She's normal.
She should.
Mm-hmm.
She should be taking, right? Is she taking that?
This is an issue we have to take into account. Again, we have to review her symptoms. I'm going fast now. She feels good. She does not complain. However, she still has some menopausal symptoms, and her periods are not as before. we have to take that into consideration. And what's more, before she started therapy, she had menstrual irregularities for 2 years. And she also reports prolonged lactation, 2 years, it's 4 years altogether. So let me go through a little bit quickly. Some facts about lactation. Lactation is a very crucial period about the bone health of a woman. During pregnancy, there is an increase in calcium absorption. So if you prescribe a large amount of calcium, vitamin D, there is no problem with bones. However, in the lactation period, you have both a state of primary hyperparathyroidism due to the PTHRP and hypothalamic amenorrhea due to high prolactin levels. So you have bone resorption, and this is pretty much high. As you see here, the BMD declines of about 5 to 10% the first year after delivery in a nursing mother. However, unlike to the prescription of GnRH agonist, because this is the same effect, unlike to this treatment, when the woman stops lactation after the weaning period, the BMD is fully restored. So this is not to discourage women to lactate. However, you have to know that during the first year after delivery, lactating women, you can have decreases as much as 10% in bone mineral density. What are the factors that are associated with no recovery of BMD after weaning? In this particular patient, menstrual irregularities started soon after the weaning period, after she stopped lactating her second child. So she never restored her menses practically after the second delivery. So this is a crucial factor about this lady. There are worries about her bone health. She has early menopause, at the borderline between early menopause and premature ovarian failure. A prolonged lactation, very close to the start of the early menopause, a low BMI, probably a negative balance of calcium, vitamin D. So what would you consider for this patient? These are the options here.
Can I? I think the first thing is before you prescribe, she was given the prescription, she should have a basic hormonal evaluation to see about thyroid function, which was not done according to the history. I mean, this woman had irregularities, menstrual irregularities, didn't have a proper workup for the menstrual irregularities. So therefore, apart from the clinical presentation, you don't have documentation that she actually went into. You agree with that? So you have to check also prolactin levels, TSH, FSH, and estradiol. This is the basic stuff.
I would check what I showed in the previous case. I would do the same here. So sure, I would check.
You agree with that?
But they were normal.
They were normal. The second thing is that a lot of women that lactate, they start having regular cycles after 3 to 4 months. That means the system works. That's why they can get pregnant. That's why you don't. Women lactating, they can still get pregnant while lactating. So the system can catch up. So unless you have amenorrhea during lactation, then it makes sense to. The third thing is that she has symptoms on 1 milligram, right? Is that, so is that enough for her?
This is the crucial point to ask.
She can take 2 milligrams.
Yes.
She can take birth control pills?
Yes.
I'm asking, I don't know, I'm not
Other suggestions?
They're the experts.
Yeah, no, I'm just asking a question.
Well, a usual practice I've seen during these years I'm dealing with menopause is that these women are advised to go on with a low dose because of fear of breast cancer and add a bisphosphonate on that. So 2 regimens, which
doesn't make sense, does it?
Doesn't make sense
Doesn't
at all.
make sense.
Doesn't make sense. So the most reasonable way to proceed is to increase the dose of the estrogen here, and I think you will agree. So let me give you some facts, and I'm over. I'm done. Here you see the effect of bilateral oophorectomy, as we heard before, on bone mineral density. And if you are talking about premature ovarian failure or early menopause, this is an equivalent condition. So we have as much as 10% decrease in bone mineral density after the performance of the oophorectomy. And this is true in women about their 40s. So this woman with all these conditions and early menopause may have fallen in this category, and maybe that the 1 milligram of estradiol at the age of 40 is not enough for her to decrease the rate of bone resorption. Here you see the fracture incidence in the early menopause is much dramatical increase in the incidence of fracture. And on the other side, here you see a very late analysis in Nordic country. From these women with early menopause, less than 20% start HRT, and from those 20%, only 50% continue beyond the first year. And what we are going to prescribe to stop the decrease in bone mineral density? Estrogen, of course, but estrogen in proper doses. And again, you see here the analysis of Professor Lambrinoudaki on premature ovarian failure. You have to move around 75 to 100 micrograms if you want to have a decrease in bone resorption. And if you compare the effect of oral contraceptive, as we proposed, and standard dose HRT, probably the standard HRT is better for bone mineral density stabilization compared to oral contraceptive. So in this patient, I would switch the regimen to standard dose HRT, and of course, I would say what calcium she's taking, and I would supplement her with vitamin D.
Questions? You agree?
Yes.
You all agree?
Okay.
Okay. So we have another
So
one?
I have,
Okay,
and there is no time at all. I had prepared 4 because I didn't know how we were going to go, but I think I have to stop here.
Do you want to finish?